How can you improve symptoms of breathlessness in a patient with chronic respiratory disease? What's the link between diabetes and frailty? And how long is a child with measles contagious for? We're considering these questions in this week's episode of the Clinical Update podcast. I'm your host, Rhiannon Ashman, and my MIMS Learning colleagues Dawn Liz Powell and Sangeeta Krishnan will be joining me shortly to discuss an intervention to improve breathlessness. We'll hear from Dr Tom Crabtree on diabetes and frailty, and then close today's show with 3 key learning points for you on measles. Over to you, Dawn and Sangeeta.
Thanks, Rhiannon. I thought we could have a look at a module on pulmonary rehabilitation for breathlessness. Written by physiotherapist Enya Danes, this module explains how breathlessness can affect a patient and how pulmonary rehabilitation, or PR, can help. Breathlessness is a multifactorial and complex symptom that can be distressing to experience. Numerous conditions can cause breathlessness, including heart failure and chronic obstructive pulmonary disease. So obviously, when a patient presents with breathlessness, the priority is to identify the cause and, if possible, treat that. However, for the purposes of this discussion, we are looking at managing breathlessness in people with chronic respiratory disease. According to Ms. Danes, patients can get caught in a vicious cycle of becoming ever more breathless. They reduce their activities because they get breathless, they become deconditioned because they have reduced their activities, and then become even more breathless because they are deconditioned.
Yeah, I can see how that could happen. So, is it possible to break this vicious cycle?
This is where PR has a role. Spruitt et al. Define PR as a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies. These therapies are designed to improve the physical and psychological condition of people with chronic respiratory disease. The aim is to promote long-term adherence to health-enhancing behaviours.
So which patients are eligible for PR?
Ms. Danes writes that PR services accept referrals for patients with chronic respiratory disease and an MRC dyspnea scale score of 2 or more. The scale goes from 1 to 5. A person with a score of 2 would get breathless if they walked up a slight hill. A person with a score of 5 would get breathless while dressing or undressing.
So if someone is accepted by PR services, what happens next?
The first step is to establish a patient's maximum exercise tolerability so that an individualised exercise programme can be designed at the appropriate intensity. The patient's quality of life and the level of their breathlessness should also be assessed. Ms. Danes notes that assessing breathlessness can be complicated, but she states that the MRC dyspnea scale can be used at rest and the Borg rating of perceived exertion scale can be used after exercise.
What should a PR program involve?
The British Thoracic Society has produced guidelines on PR, and these are accredited by NICE. The BTS advocates the need for both aerobic endurance training and resistance training. It also advises that programs should consist of a minimum of twice weekly supervised exercise sessions for 6 to 12 weeks. PR is typically delivered in a group environment, but should also involve home-based exercises. Recent years have seen developments in home-based, digital and tele-rehabilitation.
PR sounds like a very useful intervention, but given the current constraints the NHS is under, are people actually able to use it?
Well, there are some indications that there is a delay between referral for PR and commencing a PR programme. According to one report, only 54% of patients with stable COPD referred for PR start a programme within the recommended timeframe of 90 days. Ms. Danes states there are challenges with delivering PR, particularly because of travel constraints, language barriers and digital and health literacy. Addressing these challenges continues to be a national priority for PR services. Thanks for discussing this module with me, Sangeeta. As a reminder, it is available on the MIMS Learning website. It's actually part of a collection of modules we have on adjunct therapies for chronic respiratory conditions.
Thank you both. Good to learn about this intervention in more depth. On to Dawn and Dr Tom Crabtree now, who are discussing diabetes and frailty.
I'm here with Dr Tom Crabtree, who is our diabetes clinical advisor. In the first season of the podcast, Tom and I spoke about diabetes technology, but today we will be discussing diabetes and frailty. So, Tom, welcome back to the podcast.
Thank you very much for inviting me back to talk.
Right, so to start off, what do we mean by frailty?
So frailty means a state of reduced physiological reserves. That might basically means that people are less able to respond to acute insults. That might be a fall if they break their hip, that might be infections, and it just puts them at increased risk from all of those things. And that's usually because of a multitude of different medical problems that they've picked up, or it may be because their function has declined. And usually, but not always, that is associated with advancing age.
So, in the context of this interview, I'm assuming you're talking about an older person with type 2 diabetes.
So most of what we'll focus on today will be older people with type 2 diabetes, because we know that type 2 diabetes is more common than type 1 diabetes in older populations, and that frailty occurs in people with diabetes more frequently and at a younger age because of the complications that people can collect along the way with their diabetes. But some of what we talk about today could also be applied to type 1 diabetes, and both types of diabetes, in fact, will increase your risk of being more frail at a younger age.
And how can we assess frailty in an older person with diabetes?
So there's different ways of assessing frailty. There's different scoring systems. Lots of them are functional, sort of clinically judged scores about how people perhaps mobilise around, whether they're using frames, how much additional care they're needed. Others perhaps more score-based systems. So increasingly people are using the electronic frailty index, which is a scoring system that takes into account a range of different medical problems or different care needs that an individual may have, and then generates a score that then determines how frail they are. So there's different ways of identifying it depending on the situation. We're all more used to clinical frailty scoring, perhaps because that's been around for longer, but increasingly with the advent of electronic primary care records, we are seeing the use of electronic frailty scoring as well. Although we associate frailty with older age, you can be old and entirely fit with no evidence of frailty. You can also be younger with multiple medical problems and in that situation have frailty as well. So it's important to recognise that whilst there's an association between frailty and age, that they're two separate things that we're talking about.
How does frailty affect diabetes?
So it may mostly affect the way that we think about setting targets and the sort of treatments that we use, because there may be some things that we would use in non-frail individuals that wouldn't be appropriate if someone was living with frailty. And that might be, for instance, insulin therapy. It may change the targets we use in terms of HbA1c. So that's really important to recognise. There may be specific things linked to frailty. So perhaps visual impairment, perhaps problems with continence, perhaps problems with mobility, that might then have a knock-on impact to certain things or the sort of things we provide or the additional support that might be needed. So if you take, for instance, someone who may have a degree of frailty and they have arthritis in their hands, they might not be able to give insulin injections themselves, for instance, and that might be something that we need to think about if we're going down that road. And if we need to go down that road, we need to think about what sort of extra support an individual might need in order to use those therapies.
We have a webinar on MIMS Learning by Professor Alan Sinclair. And I think in that webinar, he's talking about diabetes in older people, and he mentions there that over-treatment can be a problem for older people with diabetes. I mean, how does this occur?
So the evidence for this came from some of the bigger trials from the late 90s and early 2000s. And one of the trials, the Accord trial, was actually stopped early because there was an increased risk of mortality in people with HbA1c levels at the target for which they were aiming in that study, which I think off the top of my head was 42 millimoles per mole. But they were a relatively older population compared to many of the people we see living with diabetes. And although we don't really understand the link, lots of it we think is due to the risk of hypoglycemia, especially with some of the medications that were being used at the point of that trial, which were mostly sort of your sulfonylureas and your insulin, which do have that recognised hypo risk. But I think it's also important to recognise that any medication, if it's not needed in someone who's old and at risk of frailty, introduces that risk of polypharmacy, that risk of interactions of a medication. So we should be trying to minimise, in many ways, the interventions we're giving to reduce that risk in this population either way.
Okay, so you're a GP, you're seeing an older person, they've got type 2 diabetes, and you've looked at what they're on, and you think, I think that person is being overtreated. How would you go about de-escalating that diabetes treatment?
So I think the first thing to do is to assess whether or not we do think they are being overtreated, and some of that might be assessing their frailty, looking at some of the excellent guidelines that we've got out there around the sort of treatment targets we should be setting, and some of that's going to be around collaborative goal setting, so having those discussions with the person in front of you about what the goal should be. I mean, my view would be that anyone with a significant frailty shouldn't be aiming for a HbA1c of less than 58 because you're introducing risk there. Now, when it comes to de-escalating therapies, because we think some of this risk is linked to the risk of hypoglycemia, what we should be doing is de-escalating those therapies first. So we should be perhaps stopping people's insulin to start with, or titrating the dose downwards, and then we might be considering stopping sulfonylureas. I guess the additional thing to note with those therapies is they're not associated with glucose-independent improvements in outcomes, by which I mean, as you'll all be aware, we've got lots of evidence that SGLT2 inhibitors and GLP-1 receptor agonists improve outcomes sort of irrespective of glucose levels, and now have wide recognized uses in conditions like heart failure and CKD. So actually they may be worth continuing even if the glucose levels have come down, if it's going to reduce that person's overall risk and they're happy with that plan.
Okay. I think it's interesting you're saying about these relatively newer treatments, SGLT2 inhibitors and GLP-1 agonists. I mean, while, like you say, you're seeing them in heart failure, you're seeing them in other conditions. Do we know what the risks and benefits of these treatments are in older people?
We don't fully understand the risks, and if you think about each of the drugs in turn, there may be some situations or conditions that are associated with frailty where they wouldn't be ideal. So if we take SGLT2 inhibitors to start with, because of the way they work in terms of causing glycosuria, that can increase the risk of urine infections. So that could be a problem in older populations, and it can also increase problems potentially with things like continence because it increases the amount of urine that's passed. So that could be one potential problem with SGLT2 inhibitors. The thing with GLP-1 receptor agonists is a bit more complicated, but actually you may not want to encourage weight loss in someone who's older if they've got type 2 diabetes and they don't have much weight to lose. And so if you were using it from a purely sort of glucocentric, glucose-based point of view, you might decide against it because actually weight loss in that context may not be the best thing, and there's studies going on and work going on around whether people are losing fat versus muscle that could affect function with GLP-1 receptor agonists. So both of them do have benefits in terms of cardiovascular risk, so that's important to bear in mind, but there may be individualized conversations that need to be had with patients around the potential side effects of those two medications and how they may impact their overall health.
Just going by what you said so far, and I'm sure our listeners know this, but as with anything, it's about seeing that person in front of you and meeting their needs and their wants and treating the person, not the condition.
Exactly. And actually, I think increasingly when we look at perhaps people who are older with type 2 diabetes, if we're doing any intervention, it should be multifactorial. Taking a purely glucose-related point of view isn't necessarily the correct way forward. I think increasingly we're recognizing that perhaps glucose levels to a point in type 2 diabetes matter less than using the right medications to bring glucose down, but also to reduce risk by other means in terms of like, are they on a statin, is their blood pressure controlled? So I think we need to take a really holistic view to anyone with type 2 diabetes, but perhaps even more so in an older or perhaps more frail population.
Okay, so just moving on to diabetes tech, we've seen a huge increase in diabetes tech in recent years. We've got continuous glucose monitors, we've got hybrid closed loop therapies. Could these technologies be useful for a person with diabetes and frailty?
Yeah, and I guess we can talk a little bit across both type 1 and type 2 now, because we are using CGM in type 2 diabetes, but there's no reason why someone shouldn't be able to benefit. It just means that the education we give them or the tools they need to access that technology might be different. So for instance, if you have an older individual who doesn't have a smartphone, we may need to give them a handset for them to use their CGM, and that's still worth us doing. And there's lots of evidence to say that people do still get improved outcomes with the use of technology at older age. When we did the closed loop pilot, we didn't find any difference between age groups, and we presented some data at Diabetes UK last year showing similar HbA1c reductions in individuals over 65 compared to younger age groups. So I think age shouldn't be a barrier to technology.
I think it's very interesting there that you've just said that age shouldn't be a barrier to diabetes tech, but you did comment on a recent piece of research in your research briefing that sort of suggested that there are barriers to older people using tech. Could you just expand on how we can support older people to use tech? I think you mentioned there perhaps giving them a handheld device and other things.
Yeah, and I think some of it's just thinking about how the technology will best fit into their diabetes management and their lives. If we were to go down the route of connected pens, for instance, then it may be that we wouldn't have the expectation of them to upload the data remotely at home, but we can do that for them if they come to see us in clinic. If we're using digital platforms routinely within our clinic, that might not be appropriate for older individuals. So we may think about offering them face-to-face appointments. So it's just about tailoring the care we give around the technology so they get the benefit without necessarily introducing additional burden or struggles for them. And actually some of this is for us to lobby industry to make sure that they're thinking about health inequalities in terms of age being a barrier to access to what they're producing in their pipelines moving forwards.
To clarify, with an older person, just because they're older, they're not necessarily going to be frail, and just because they're older, they're not necessarily going to be against digital technology.
Completely. Yeah, I would completely agree with that statement. I mean, there's also plenty of younger people that aren't tech savvy. Everything goes both ways, doesn't it? So I think you just have to try to tailor care to the individual in front of you and take a really holistic view.
Thanks so much for speaking with me today, Tom. Do check out Tom's research briefings. Each month he provides expert commentary on the latest diabetes trials. And if you want to hear more about his thoughts on diabetes technology, do listen to episode 2 of the first season of the Clinical Update podcast.
Hi, I'm Emma Bauer, editor of the website GP Online and host of the Talking General Practice podcast. If you're interested in what's going on in primary care across the UK, do come and check out our podcast. Talking General Practice is out every Friday and includes discussions about the key issues and news stories affecting general practice and interviews with GP leaders as well as inspiring GPs and others who are making a difference to patient care. Just search Talking General Practice wherever you get your podcasts to have a listen.
Now it's time for our 3 key points segment, highlighting 3 important take-home messages from one of our learning modules. This week we're featuring a module on measles by Dr Pipin Singh. Cases of measles have been on the rise, as I'm sure you know, over the past couple of years, reflecting a fall in immunity. So, Sangeeta, can you give us our first key point?
Sure. So our first key point is about when measles is infectious. The incubation period of the measles virus is 10 days. This tends to be followed by 2 to 4 days of prodromal symptoms before the typical rash develops. Patients are infectious from when symptoms appear to around 4 days after the rash disappears.
Our second key point is that given measles is infectious prior to the rash appearing, consider isolating those with a suspected case. For example, if you are aware ahead of time that you will be seeing a person with suspected measles in your surgery, if at all possible, consider isolating them from your main waiting room. Or referring them to hospital, call ahead so that the appropriate isolation can be arranged.
And the final point is not to forget other differentials. These may include scarlet fever, parvovirus B19, roseola, meningococcal sepsis, or drug reactions. Some of these differentials will be obvious from the history, but some infectious diseases may not be as easy to distinguish, and rashes are common in children. In measles, the classic prodromal symptoms include a high fever plus the 3 Cs: cough, coryza, and conjunctivitis. In fact, conjunctivitis, in association with the other 2 symptoms, is particularly suggestive of measles. The rash is maculopapular and often starts behind the ears and on the face, then spreads to involve the trunk. Okay, so our 3 key points are: patients with measles are infectious from when symptoms appear to around 4 days after the rash disappears. If possible, isolating patients with suspected measles from the other patients in your waiting room. And finally, don't forget other differentials. It can be tricky to distinguish measles, but conjunctivitis in association with high fever, cough and coryza is particularly suggestive. And an image of the classic measles rash can be seen in the module on the MIMS Learning website. Thank you for joining us this week. All of the content we've discussed in today's episode is available on the MIMS Learning website, with links in the podcast notes. We're looking forward to our next episode, where we'll be discussing generalised anxiety disorder and hearing from Dr Ivan Coe on torus fractures of the wrist in children. Bye for now.